Hey, welcome to another case study look at a beginning case that's extremely difficult, and we did talk about the upper, so take a look at that video for that. But we're going to look at the lower on this one at this point. But let me just get through the treatment and assessment. It is a bit challenging on this one because the collapsed bite, the repeatable bites, orange videos, orange, failing front teeth, combination syndrome. Posterior supports are red. We got red on sinus bone. We don't talk about that right now, but ridge height is a red. IA nerve is orange. Bone density is pretty good. Facial bone, the constriction, orange. So take a look at that. But this is really challenging because we're looking at what is this partnership going to include? Are we going to keep the lowers? I don't think so. This is an extreme dry mouth case. Patient's kind of compromised. Too many medications just kind of rot out the teeth. So this is possibly an all-on-4 case, but let's look at the bone a little closer. Let's look at how the shape of the bone is going to affect your longer-term placements here. So in my mind, you take the teeth out, give the patient a denture. Don't do immediate placements because the remodeling of the bone here is a little bit too unpredictable, and you want to make sure that there is this healing pattern that's going to be more predictable, because that denture piece is going to help collapse and shape that bone as well as anything. Unless you want to augment the bone and really jump in and throw the implants deep, oral surgeons like to do that. I guess some periodontists too. I personally don't. I'd rather see natural anatomy there. I'd rather see some healing pattern going on and more bone there. But, you know, I understand why the augmentation would go across here and take away the bone once you take out those teeth. So, you know, it's, you know, preference, I guess. So, anyway, let's look at the CT here. And what we're going to look at really quick is you can see the foramen here. Let me show you how that looks a little bit more closely right here. Here's where the nerve comes out, and you can see how it starts to come, and it's going to come out right here. So it's coming right up here. So I'm going to hold that arrow. It's right there. Right? It's coming like that. So it really kind of hooks. Let's go back to a wider viewpoint. So what do you do here? Are you going to do angled implants? Well, let's look at posterior to that foramen and where exactly is it? Here we go. Let's increase that viewpoint for the lower arch. And oh yeah, this is a very difficult skeletal position. Look at the skeletal position here. Not so good. Our nerve is, let's find that again. Go to a small slice view, and if I'm looking, I'm going to put that line right on top of the nerve right there. So when I go to this view, I know exactly where it is, and it's right there. So if we're to put an implant in, is this one of those short implant cases? I don't like it, but let's do it 8.5 by 4.2 diameter, and that's what that's going to look like. And if we go there, I'm going to put it down below the bone there. And where are we at? Yeah, we're right on the nerve. So if you're a Bicon person, I guess you can try to bury something there. I don't really like it. You still have to bury it a couple millimeters down anyway, so you're kind of stuck. So I'm not really so clear on the whole Bicon thing, only because you're down to 6 or 8 millimeters anyway. So would that work? Yeah. Could you put a locator attachment on Bicon? Yeah, you could. So maybe use a 6x6 or a 5x5 Bicon. It's like a little ball you tap in there. That would be interesting. The other obvious modality is the all-on-4 angulation of the posterior implants right around that foramen. What I like about this is that I know exactly where I'm going to go in and the angle I'm going to go in at. Once you take this tooth out, you know you're starting, let's say here, But let's put an implant in there. Actually, what you could do is angle this line right where we want it. Should be right about there. But one of the things I don't like so much is how dense the bone actually is. Some of this is the tooth structure, but it's really hard. Here's the nerve. So when it's really hard like that, not so fun. I don't have fun with that one. So 4.2 by 11, it's a little bit on the wide side, maybe a 4.0. You know, do a 3.5, you know, it's hard to say. That's what it would look like here. That could work. Don't really like it. I would probably try to get something thinner. Let's do a 3.5, or it says a 3.7, I believe. And this is where I just feel a little bit shaky on the stress that this kind of implant is going to take. So, yeah, this is where I'm not the most trusting guy looking at it from here, you know. Very difficult. Maybe this is a surgical guide placement, something like that. Very challenging, but it's doable. It's not impossible, but yeah, that's a tough one. All right, let's go to the other side. If you can get the posterior ones in, you're probably going to get an anterior one in. If you augment the bone here, let's do that. That's actually a good exercise too. You could do that with the CT. You're going to augment the bone down to probably about here. So you're going to take it all the way down. So your implant actually would come down quite a bit. So let's see if that makes life a little easier. Let's zero in on that. Yeah, I guess it would. Yeah, still a 3.5. You could do a 4.0, get a larger mount on there, get a little more girth on it. That would work too. I'll just stick with this one in there. So let's think about the augmentation of that bone. Once you take the extraction out, knock it down about 4 to 5 millimeters off the top. Bring it even to this more posterior area. It's going to be easier to deal with the prosthetic, the lip, and everything else. So might be the best thing on this case here. So let's look at this one. What is this going to look like over here? And same thing. All right, let's do the same thing. Even more narrow. Not good. Definitely a challenge. Will the healing work? Possibly, yeah. So that would be that, and now we need a couple more, and you know, this would work because we're going to be knocking out that top part of the bone. And here's where the constriction basically tells you have to do some augmentation. Let's do another 3.5 here. So this is all small diameter implants here. Yeah. Yeah, see, here's the constriction. It gives you a problem even when you augment the way of the bone. So you're going to have to do that. And that's even lower. So you definitely have to augment the bone here and take it away. You can do it all on 4 kind of case. You actually could do this as an all on 4 case. You're going to get a lot of stability. I just don't like the angled ones and the density of the bone. It's going to be harder for a patient to heal around those. And bad part is once you lose bone, especially on that lower right side, man, you're going to be really in a tough bind to try to get that bone back. So I personally never like to risk a situation like that. And I certainly would not do it at this point either. So I'm not a fan of this immediate load all on 4 model at all, and this is one of the reasons why is because this kind of case here, this patient can't afford a blowout of an implant and blowing out the bone, especially on this one side. You lose that, you've got a problem. Here's a little bit of a saving grace. I want to look at this real quick and just to see, is there a possibility for something here? Very clear that there's a tooth there that we are maintaining some bone structure going up. So let's look at that. And this looks really horrible. It looks a little better. You can just see all that decay right there. So the bone density is pretty good. It's a little bit on the hard side. If we are looking at, let's say here's the nerve, here's right down the middle of that tooth. If you grafted that and we got that bone to stay, let's say it looks now kind of like this. Could you do something there? Man, you know, that angulation is kind of killing me just looking at it. Let's do a 4 by 8. So this is 4.2 by 8 and no. Oh, boo. Yeah, we're right onto the nerve. You know, you got to be a gutsy surgeon and put that one in. Let's move that more in the anterior here. Could you do that? Better. Not a fan. Bone is very dense here, not very well healing, and then you've got a nerve and you can't feel the density change. You're going to come right into the nerve. Definitely a skilled surgeon could get something in there. Just don't know, or I would trust that the patient could actually heal around that site. So if you could get something there, I would get it there. I would even try to do the bicon over here. If you're going to do all of this, throw that in there, throw something in there, throw something in there. Just because this is a lot of load that's going to go onto this. Or is it? That's the question. This patient has a very compromised situation on the upper. These small diameter implants can only handle so much. I've seen implants crack, especially the small diameter ones. They crack at the neck, and then you're taking the implants out. Not so fun. This one would really help support this idea. How long would that last? Hard to say. The issue also comes down to how much could this patient actually bite, because the upper is so compromised as well. So she's got miracles to happen up here with grafts and trying to get bone to grow there and get implants up there. This is also less of a miracle, but it's still possible. This is possible, and you're only going into kind of that premolar molar occlusion on 12 teeth. Against an upper denture, this should last a while. I doubt she'll ever get the power to bite on it. The upper denture is severely offloaded. That's something I did not talk about yet, or even show, is that the upper here is very, it's kind of got a weird arch to arch positioning. So she's very class 3, skeletal class 3 here in terms of the bone and the bone. So you would want to put her more into an edge to edge. So you're going to augment down here. You do nothing there. So you're going to be coming edge to edge into the bite here, which would be probably very different than what she's used to. But it would be very functional, and that's the whole point. It'll look good. You can make it look good, but it's a challenge. So this is definitely an upper challenge case. It's not a case that I would completely ignore, but or tell the patient I can't do anything about. But I would say you stage it, and you stage what you possibly could do here for the patient, and just say, this is all I could do. Let's start with grafts. Well, let's get you a couple dentures. You're going to hate it. You're going to struggle. And that's all we could do. We'll evaluate it in 4 to 6 months. Look at the bone, evaluate it then. Try 1 or 2 implants. See how that lasts. See what it takes. Start with the hardest side first, because if you start with the easiest side first with implants and it's successful, what good is it if you can't address the other side? So, definitely a challenge. Take a look at the other video on this case. It's definitely interesting. We do have some follow-up information on this case as well, so follow those as well. Thanks for joining us. Thanks for joining another Renew case study. If you have any comments, please comment, but also look for some of our live feeds. Like us on Facebook and subscribe to us on YouTube. So thanks a lot for joining.